I'm going to record. I have to escape. All right. I would like to thank everybody for joining us today for what is going to be our last of our summer seminar series on Wednesdays at noon. The series will start up. The regular MindCORE seminar series will begin again this fall. Much like the summer, it will be virtual, and typically our speakers for the regular seminar series are researchers from not from Penn. So that's one thing that actually makes the summer kind of special, is that we get to hear what's happening on our own campus. And I know that we have a couple of faculty who have been attending these to hear what their colleagues are doing. And so today we're actually going to be joined by our last speaker, Kate Davis. So just to give a little bit of a reminder of what we are, MindCORE is an interdisciplinary effort at Penn to understand human intelligence and behavior. And we bring together faculty and postdocs and students from across campus who have diverse approaches to the study of the mind. And so that is what we do. I will share our website for future events in the notes section in the chat function. So one little point of business, you can ask questions in the chat. Just feel free to post any questions there. I will keep my eyes on them. And then when we have a break in the talk, either at the end or in the middle, I'll make sure that our speaker gets the questions. So I think that's it for the housekeeping. Thank you all for joining us. And I'm going to turn it over to Dr. Davis.
Great. Please, I'm in the hospital. As you can see, my home. Any connectivity issue, just please speak up, because of connection sometimes in the hospital with my laptop isn't as great. As mentioned, I'm Kate Davis. I'm currently a assistant professor of neurology. I'm a clinician scientist. My clinical work is focused on treating epilepsy patients. And also my research lab is focused. So we're a very translational lab on improving treatments in epilepsy. So I'll talk about some of the work that we're doing in the lab in the talk, but before doing so, just wanted to give some background on how I got to where I am right now, which is something that I think that all the MindCORE speakers are being asked to do. So I did go to, I went to undergraduate at Brown, and then I was in a one-year program at the NIH called the Pre-IRDA program that still exists, where you work on campus at the NIH with intramural investigator there. So I worked in the Mental Health Institute for a year before I went to medical school at Yale. When I was at Yale, I had been a neuroscience major as an undergraduate, but I ended up doing my research thesis with someone who is very well known now in the field, Hal Blumenfeld, who actually also does a lot of imaging work in epilepsy. So that mentor was very influential in my career path, which I think is a common story you'll hear from faculty, that the people they work with along the way really influence their interests and inspire them. I then went to Penn for my neurology residency, followed by a year of epilepsy fellowship, followed by a master's in translational research at Penn, which is one of the internal master's programs here that a lot of physician scientists who didn't do a PhD with their MD do additional training after they finish their clinical training, to allow them to then potentially become an independent clinician investigator. I think where my story gets a little bit different is I did have twin girls when I was in my last year of residency, which is, as you can imagine, a lot of work and challenging, but I still continued on and did the master's degree. I did then have two additional set of twins, which are boys, now 10 years old though, when I was in that master's program. And I ended up, because of all these family pressures, leaving academic medicine for what turned out to be just a year and a half, but worked at a more local hospital, building my own epilepsy unit and epilepsy monitoring, open an epilepsy monitoring unit there, before getting an offer to come back to Penn to build, again, my own research lab. I think it's an unusual path, but I think important one to talk about. And I think particularly when you have very young children, there are a lot of pressures and it can often feel very overwhelming. But as they get older and things change, I think I ended up concluding, and I really believe this now, that the work-life balance that being a physician scientist allows for is really very well suited to being a working parent, because although I have a lot of different things that I do, I teach, I have my research lab, I see patients, there's a lot more on my own terms that I can control. I personally have to stay very well organized, but I really enjoy having really my own, I can build my own, kind of create my own path. So I'll end there so I have time to talk about it. But when I came back to Penn, which was about 7.5 years ago, I really came back with a kind of renewed passion for the work that we're now doing in my lab. And I successfully went on to get a training grant called a K-23 from the NIH. And then I recently just received an R01. So that's the kind of currency for becoming independent. So that's kind of where I am right now, but it's been a long road that I've enjoyed every step along the way. So I will just go right into the talk. So if I can, okay, 1 second. I think I have to click on something. Okay. There we go. So I just have a few disclosures. And then just the outline, I know there's a diverse audience, so I'm going to give some background, just a clinical background on why we think the problem that we are addressing is important. And then I'll have a case presentation of a patient that will take you through some of the different research projects that we're working on, which I think will keep it kind of connected to the translational part of our work. So epilepsy still has a lot of stigma associated with it. And I think many people think it's a lot less common than it really is. So it's incredibly common, occurring in about 1% of the population. You can see the numbers here. There are about 3 million people in the United States alone. About 1/3 of all of the patients worldwide that have epilepsy have drug-resistant epilepsy. And in this more severe type of epilepsy, there's an increased risk of injury, death, included sudden unexpected death in epilepsy, which you may have heard about because of some recent celebrity deaths that have occurred from SUDEP, including Cameron Boyce, I think, last summer. In addition, patients often have their driving limited, have a more difficult time finding gainful employment, and suffer from social and psychological harm. So how do we define drug-resistant epilepsy? It is unfortunately a really simple definition. The definition is failure of 2 appropriately chosen and tolerated seizure medications, either as a monotherapy or polytherapy. It's unfortunate, 20 or more epilepsy, and unfortunately this number has not shifted at all. The large drugs. So the drug that's tried, if it's appropriate, no matter which one of the appropriate chosen drugs, you get very quick diminished returns when you try additional drug. And so this is the population that our lab, this purple, that drug resistant. So what do we do with these patients? There are different treatment options. Surgical options today. There are also some other less invasive devices such as the vagal nerve stimulator, diet therapy, which is usually used in the pediatric population. And of course, you can always try more and more epilepsy drugs, but I just pointed out that that doesn't work very well. So within brain surgery, there are a lot of options. We are doing resective surgery very frequently. In the last few years, less invasive approaches have come to the clinical use, including laser ablation, where you can, in the MRI scanner, just target one smaller area of the brain to burn to try to cure a patient's seizures. And then we do have some invasive devices that are now approved and used clinically, including the NeuroPace responsive neurostimulator system, which is essentially a defibrillator for the brain, where electrodes are placed on the area of the brain that we think seizures are coming from, and they are actively recording, and when they detect bad rhythms, they'll give a stimulation trying to defibrillate the seizure or stop the seizure from occurring. And then we also have deep brain stimulation, which is used, as you may be aware, in Parkinson's, but more recently in epilepsy, but targeted at one of the main epilepsy networks, which is the anterior nucleus of the thalamus, which is very involved in PAPE circuit and the mesial temporal lobe networks. So we have all of these options, but unfortunately, we really do not have clinical biomarkers to tell us what is the best option for a given patient. And that's really the overarching main goal of our lab, is to develop non-invasive markers that help to determine the best therapy for a given epilepsy patient. So I can't not point this out. Unfortunately, although we'd love to have all of these drug-resistant patients evaluated for potential surgical intervention, because we know that's the only way to cure them. As I mentioned before, there's a lot of stigma still surrounding epilepsy. There's a tremendous treatment gap that we really don't fully understand. But unfortunately, there remains a 20-year wait where patients will be suffering from drug-resistant epilepsy before they end up getting evaluated at a center like Penn. And so you may think that we'd have many, many, many more thousands of surgeries per year than we do right now. And that's also, kind of a clinical goal of mine, is trying to increase the awareness and the ability for patients to get a full evaluation for potential cure. So I'm just going to go through some of these surgical options in a little bit more detail and provide some data as to why these are options that we consider in our patients. This is now very old data, but the data supporting temporal lobectomy in epilepsy patients actually comes from a really important study that was done in Canada, where, as you may be aware, with their different medical system, they may wait quite a bit of time to get, for instance, a surgical evaluation. So they were able to ethically randomize patients with drug-resistant temporal lobe epilepsy to continued medication therapy for a year or surgical intervention with a temporal lobectomy, and showed very clearly that the seizure freedom rates were much improved with the surgical intervention. So I think this might have gotten out of row. So I'm going to do this slide first, because I think the slides got flipped. But so, when we're considering epilepsy surgery, sorry, I apologize. I think I'll start with this. So I think I see Andy Revel on this call, as one of my graduate students, who I told him not to come on this call because he's heard most of this talk before. But he has told me that this meme breaks meme rules. So I apologize, Andy, that you're seeing this meme again. I don't understand meme rules. But so essentially, when we're thinking about epilepsy surgery, we're using all these different data points, from what their scalp EEG looks like, what they feel during their seizure, which is seizure semiology, what their MRI of their brain shows, what their PET scan of their brain shows, their neuropsychological testing. And we're trying to generate hypotheses about where in the brain the seizures could come from. And ideally, you want all of those things to line up. All your ducks should be in a row. And then you're the ideal surgical candidate, which would be, for instance, a patient that has a clear scar in their hippocampus, their EEG comes from there, there's neuropsychological deficits from that same spot, etc. But most often we're in this situation where there's a lot of the data is kind of in the same ballpark, but it's not very clearly evident where the seizures are coming from the get-go using non-invasive data. So as I mentioned before, we're using all of these different data points to generate hypotheses about where in the brain the seizures could be coming from when we're considering patients for an epilepsy surgery. And in these patients where we don't have a clear slam dunk hypothesis about where the seizures are coming from, we are very frequently deciding to do a more invasive test with intracranial EEG. And this is just some examples of some of our patients who have had intracranial EEG. And this is showing some of kind of the fancy imaging co-registration that we do in our patients, both for research and clinical purposes. But you can see that there are a lot of different electrodes. All of these little dots are along the shaft of an electrode inserted perpendicularly to the brain, going through the skull. This is done by a trained epilepsy neurosurgeon. And in my mind, this is the most invasive test in all of medicine. So I haven't had anyone be able to argue me out of that opinion. But it is truly a test, and sometimes at the end of the test, we don't get an answer for a patient. And even in patients who have undergone intracranial EEG, in this case, this is a newer method, stereo electroencephalography, or SEEG, and they undergo surgery after that, a resective surgery, a large number of them continue to have seizures. So a little bit more, around a third of patients. And this paper that I'm just showing here is from a European group that has been doing SEEG for a lot longer than the United States. So we've more recently moved towards this newer intracranial EEG monitoring approach. So I kind of mentioned this before, but I think you probably kind of have gotten the idea that I believe that there is a very important clinical need to develop non-invasive, reliable tools to localize the seizure network while minimizing morbidity to our patients. So we are right now using, as I mentioned before, a combination of clinical data, various multimodal imaging data points, and scalp and intracranial EEG to make these decisions for our patients. And often they require intracranial EEG. And this gory picture in the middle is actually a picture of electrocorticography, which we still do sometimes, but this is the older intracranial EEG technique that the United States has been largely moving away from, although some centers still use it, where you can see the whole skull is removed, a huge electrode grid is placed down on the cortical surface, and then these patients have their come up to our epilepsy monitoring unit, and sometimes for weeks at a time, to capture seizures and record that data to help to decide where surgical intervention may be successful. And this is, as I mentioned before, incredibly invasive. So developing tools that are not as invasive or minimizing the need for this invasive testing would be a big win. So how do we localize the seizure network currently? And this is a very busy slide. I adapted it slightly from a recent review paper from last year and added just one new modality that we studied at Penn. But you can see this is color coded by whether something's experimental or not, with the green colors being experimental. But there are a wide range of functional and structural measurements, both traditional imaging and EEG data that help us make these decisions and that we use to find the epileptic focus. And so I'm going to go through a few of the research projects our group has worked on in the last few years, utilizing different modalities here in this figure. But before doing that, I'll just introduce the patient that I promised that I would talk about. So this is a real patient of ours. He, at the time of the surgical evaluation, was 37, right-handed man with drug-resistant focal seizures. He'd had his first event in 2008, which was a staring event followed by confusion and agitation. The following year, he had unwitnessed fall and they suspected seizures. He was started on a seizure medication. And then he started having staring spells, episodes of strange behavior, and convulsions. He did have the convulsions eventually controlled, but continued to have the staring spells with loss of awareness, and was on 3 seizure medications at the time of the epilepsy evaluation, and had no identifiable seizure risk factors. So he had actually had some initial evaluation in Hong Kong, So we had some access to that data, but then repeated studies here in Philadelphia. So they had captured 2 seizures on scalp EEG, which were focal impaired awareness, a seizure, and then a focal to bilateral tonic-clonic, so that progresses to a convulsion seizure. They had termed those seizures to be of unclear onset. And then when we repeated the study 2 years later here at Penn, we found left temporal slowing and epileptiform activity. Occasionally there was abnormal activity on both sides. And then we captured 3 seizures. And what he did during those seizures, which is what we call semiology, was he stared, he had leg and pelvic movements followed by bicycling, and he had a left hand nose wipe seen after one of those seizures. I point that out because these types of clinical features that a patient has during a seizure, including that nose wipe that's highlighted, have been studied, and we know that some of them have very high predictive value in terms of where seizures are coming from in the brain. And on the EEG, 2 of the seizures had a lot of artifact from movement, which happens a lot with scalp EEG, and 1 seizure had clear left temporal onset, but then spread to the right quickly. Other relevant data points, the neuropsychological testing showed, interestingly, right greater than left and bitemporal dysfunction. So that's sort of discordant with that left temporal findings on EEG that we suspected. So first I'll talk about a study using high field or 7T MRI, resting state and structural data. So 7T MRI was recently approved by the FDA for clinical purposes, but across most of the United States, there are actually very few 7T MRI scanners, and the majority of them are intended for research purposes. We do have the FDA approved scanner here at Penn, but we currently acquire data on our patients under a research protocol. And so you can see here, so just kind of, this is the strength of the magnet of 7T. The clinical standard previously is 3T MRI, and that's really what's done mostly for clinical purposes. So you can see here, this is a normal 7. You can hope appreciate that you get pictures of hair centered around the hippocampus, which is part of that we used on in the study I'm going to discuss. So I just want give information about why it's important problem. So temporal lobe epilepsy, you can see here, about represents 2/3 of all partial onset epilepsy. And unfortunately, within that group, about 1/3 of them are what we call non-lesional or MRI negative. So the remaining have something called mesial temporal sclerosis, which is a scarred hippocampus. We know if we see scars or lesions like that on imaging, that it substantially improves surgical prognosis, up to 4 times improvement. Okay, so the aim of this study was really trying to use that high resolution 7T data to uncover network hotspots that were responsible for a patient's epilepsy. As I mentioned before, we know that structural lesions or abnormalities on clinical MRI predict good surgical outcomes. But what we aimed to do here was look at whether functional abnormalities could uncover hidden structural abnormalities and predict outcomes, seizure onset, and potentially in the future even issues that are very with epilepsy. So the goal of the study was structure using the structural from 7T resting state, which is a functional measure. The focus of which I meant that includes the hippocampus, as you can see here, and is connected to surrounding structure. This part of the brain is really important in epilepsy overall, and a very common cause, as I mentioned before, of epilepsy. And we have a lot of data that within the mesial temporal lobe, distortions or abnormalities are the main cause of epilepsy. Upon pathological studies from human imaging, invasive intracranial. has working on, unfortunately, this person in the building a mesial temporal specific template, visualization, and these are just some of the work that we've done with. But in this study, this was done by Preya Shah, a recent graduate from the MD PhD program who just started her radiology residency. Wants to go on to become a neuroradiologist. So she, as I mentioned before, was using the high field 7T MRI data, and we had a cohort of patients with MRI negative or non-lesional temporal lobe epilepsy and temporal lobe epilepsy with mesial temporal sclerosis. And not surprisingly, across the hippocampus, and then the following, you see hippocampus all the way to the left, and then the following are all the subfields of the hippocampus. Not surprisingly, we could differentiate based upon volumetric data at the whole total hippocampal level and at the subfield level, a difference between patients that had clear mesial temporal sclerosis or scarring of the hippocampus from a non-lesional case. So that is really just validates that our segmentation of hippocampal subfields was good. So before going into the next part where we look at the resting state, I'm just going to give this like super brief primer on network analysis. So you may have heard a bit about network analysis. It's being used very broadly in neuroscience now, but some very simple definitions. You define nodes, which are pointed out here, and then the connections between those nodes are edges. And then you can look at, you can then create adjacency matrices based upon these variables, and then go on to look at various network measures based upon that. So I won't go into great detail here, but just if you're interested, there's a lot out there that you can read about network analysis. And then I'll give you the specific example. So what Preya did was she used the subregions or of the subfields of the mesial temporal lobe, and then created both structural connectivity networks and functional connectivity networks, and then went on to carry out network analyses. And the specific network measures that we looked at here are defined above at the top of the slide, and that included connectivity, strength, clustering coefficient, and efficiency. And in using those measures, we are able to interestingly differentiate between the patients with mesial temporal sclerosis and MRI negative temporal lobe epilepsy using the resting state data. So this was a pretty exciting result indicating that resting state hippocampal subfield networks show promise as a biomarker for lateralizing and identifying non-lesional or MRI negative temporal lobe epilepsy patients. And so I sort of went through that for these first points. I think, as I mentioned before, I think that this is shows promise as a biomarker, and really where we see a lot of the work that I'm going to be going through today is to add these biomarkers together in a machine learning context to identify seizure networks non-invasively at a patient-specific level. So the next study I'll just talk about is using a PET, which is FDG PET. This essentially looks at the glucose utilization in the brain, and in between seizures, we expect that there is a decreased utilization of glucose or energy in the area that the seizures are coming from. This is an established method that we use clinically in all of our patients, but it's used in a very qualitative way. So what we do in our weekly surgical conferences as we, along with our nuclear medicine colleagues, just look at these images and look for asymmetries that may be relevant to the patient's case. But it's a very qualitative task currently. So this was a paper that's now under review that Lohith Kinney, also a recent MD PhD graduate from Penn, who's starting his radiology residency as well. did, and essentially he used a available software package called SSP that allows you to make quantitative measurements of the PET and then co-registered that with the patient's MRI within it, and we used a particular atlas to do that called the AAL atlas, which is a very commonly used atlas. We also then inputted some simple clinical variables that we use in our patients, for instance, the EEG localization and the qualitative MRI interpretation. And that we then used to generate a feature matrix and ultimately went on to apply a random forest classification, which is a type of machine learning. And in doing so, we were able to identify the features that predict poor surgical outcome, and also create a prediction of surgical outcome in a separate cohort of patients. So these are just some examples of the patients in the study and the type of data that we used. I won't go through this in great detail, but certainly if anyone has questions about any of these things, just reach out to me, or we can, if we have time at the end of the talk, come back to things. So this is a kind of complicated slide, but we essentially looked at various different models and tried to see if we could predict surgical outcome in the patients. And the take-home point of our findings was that we were able to, by using quantitative PET values, improve the prediction performance of our models by about 10%, up to a 70% prediction of outcome in a large patient population. And these were all retrospective patients that had undergone a temporal lobectomy at Penn. So we thought this was a pretty exciting finding, and hopefully it'll get accepted fairly soon. Before, we were also able to identify the important factors in prediction, and didn't hypothesize these came out from the model. So won't go through this in detail, but portion of the temporal thalamus, which is well, and parts of the brain show important. And finally, Lohith created a GUI so that other investigators could easily try to replicate and use this this tool in their own patients, which is something that we really do try to do in our collaborative lab group. Make all of our pipelines and source, bring them to the clinic in the near future. So the next that I'm going to talk about is something called CEST. This is experimental. I mentioned earlier, you caught it, that this imaging modality that we developed, Dr. Ravinder Reddy. But before, just a quick primer why this might be relevant to epilepsy. So many of you may be aware that glutamate is the most common excitatory neurotransmitter in the brain. You're probably not aware that there's prior human evidence from microdialysis at the time of temporal lobectomy, and also animal data supporting the hypothesis that glutamate is increased in between seizures in the seizure focus. There's also data that there's specific enzymes that are impaired in the glutamate-glutamine cycle in epilepsy. And then finally, many of our epilepsy drugs target the excess excitation present in epilepsy. I think it's the very simplest view of epilepsy is really seeing it as being a mismatch between the excitatory and inhibitory balance. So it does really make a lot of sense that the most common excitatory neurotransmitter in the brain would be critically involved. So this is, just as I mentioned before, showing a cartoon of the glutamine cycle, and there are several enzymes that have been shown to be downregulated and upregulated, as here on the bottom, in epilepsy. So both of these changes lead to a buildup of glutamate and overall increase in glutamate in epilepsy. So what is glucest? So glucest is a type of CEST imaging, which is chemical exchange saturation transfer. Kind of in simple, a simplified version of what this is essentially it allows you to indirectly measure small molecules of interest that would not be able to be measured with conventional neuroimaging. So in this case, we target the hydrogen group of glutamate, and that exchanges with the water pool, and essentially you can measure the difference in the red hydrogens versus blue hydrogens here, and that's termed the CEST percentage. So you're getting an indirect measure, as I mentioned, and so there are a lot of different types of CEST imaging. glucest particularly targets glutamate. So our first paper using glucest was in MRI negative or non-lesional temporal lobe epilepsy from a few years ago now. We looked at, mainly focused at the hippocampus, and found that in all of the patients in this study, the hippocampus of seizure onset had elevated glutamate as measured by glucest, which was a really interesting finding. This was just one of the patients that subsequently after the scan had undergone intracranial EEG, and we had very good evidence that that's where the seizures were coming from based upon the invasive intracranial EEG data. So back to our case summary. So I'm going to you probably all forgot what we went through before, but in summary, the patient's seizure semiology, meaning what he did during the seizures, sounded like it was likely mesiotemporal onset, but spreading frontally, which some of the bicycling type movements, and the semiology itself was poorly lateralized, but that ipsilateral nose wipe is usually the same side of the seizure. So that was on the left, so we slightly favored a left onset. The EEG was a little bit stronger to the left. His brain MRI was non-lesional or MRI negative, and he also had undergone a 7T MRI, which on visual inspection was also non-lesional. The PET had some mild left anterior temporal hypometabolism, and then we went through the neuropsych data. He underwent, which we do in rare patients now, something called a WADA test, which is where sodium amybarbital is injected in the nuclear medicine suite into the one carotid, then the other carotid, and it basically is a barbiturate that shuts down half of the brain for several minutes, allowing the neuropsychological team to rapidly do various memory testing. It's an invasive test, as you can imagine. And based upon that test, we knew that his language was better supported by the left hemisphere, but interestingly, his memory was better supported from the right hemisphere. So with all this data, we thought there was some discordant data from the clinical notes. We are concerned for bilateral temporal disease, which can happen, but we favored slightly it being left onset. So this patient actually underwent intracranial EEG with a SEEG implantation. This was the implant plan with SEEG. We are targeting with electrodes our primary areas of the brains that are primary hypothesized regions of being in the seizure network. So he had, I think 11 electrodes placed. Interestingly, there were some limitations because of a thin temporal bone that we were unable to get the temporal pull, which becomes relevant in some of our results I'll go through. So you can see here a picture of the brain MRI of this patient and the electrodes and the coursing through the brain after the implantation. I show this to, again, stress how invasive this procedure is, but also to show that there is a risk of hemorrhage associated with implantation, and there is in fact some hemorrhage on this patient. And as I said, is here at the bottom, the hemorrhage rate is, per electrode is estimated to be to 1 to 2%. So if we can even limit the need for, from 11 electrodes down to less, that would be a substantial decrease in morbidity for these patients. So what did his intracranial EEG showed? So in between seizures or interictally, we did see frequent epileptiform discharges in the left hippocampus. Occasionally also saw some epileptiform discharges in the right hippocampus. And then he had 5 seizures, all of them with left hippocampal onset. All of them looked similar to each other. We saw onset at the LA2 to 4, which is within the hippocampal region. And so we thought that that was likely the area where we were very close to it. And then there was some spread to the right side, but a bit later, 12 to 20 seconds later. And this is just an example from this patient of his EEG. And you can see highlighted here that there's the start to the seizure. These are all these electrodes, recording from all these electrodes inside the patient's brain. You can see the spread pattern. And typically we have, in this case, the left side of the brain is the top half of the screen and the right side of the brain is the bottom half of the screen. And so how do we interpret this? Unfortunately, it's still done qualitatively. So I personally interpret these in patients. And so we'll zoom in on certain areas and what's called changing the paper speed, which really is back from when EEG was on paper, but spreading the number of seconds out so you can more finely tune, look in at whether there's some subtle high frequency activity in one region or another. But there's a substantial problem with inter-rater reliability, which I've actually published on before, even with experts from centers like Penn. So the kind of final piece of what I was going to go through in the last few minutes is connecting structure and function in a different way. So we talked about some measures of structure and function earlier, but in this case, we'll talk about something a bit different. So this is clearly something that is of a lot of interest to the neuroscience community. And there have been a lot of papers looking at structure and functional relationships in epilepsy. These are just some of them. But the majority of those, actually all of them, used non-invasive functional data, such as resting state, BOLD, as the functional measure, instead of another functional measure that we used, which is the intracranial EEG itself. So in this project, we actually were using diffusion tractography called high angular resolution diffusion tractography, which is acquired on MRI from our patients, and then looking at functional measures on intracranial EEG. And the goal was to look at how structure and function are coupled between these two modalities. And our primary hypothesis was that seizures were spreading along the underlying structural networks of the brain. So kind of how is this done? Similar to the PET study that I showed you before, we pulled these data points into the same space. So we take the MRI, high angular resolution DTI data, and then the functional network data and pull it into a subsampled AAL atlas, the AAL 600. And what we saw was that during seizures, as we hypothesized, there was a substantial increase in the structure function correlation. So really indicating that the seizures were spreading along the structural networks of the brain. There was at baseline a substantial relationship between these, as you'd expect, but that was greatly increased when patients went into the seizure state or the ictal state. So what do we do next with this project? This was also Project Preya Shah published. we carried out a virtual edge resection approach where we essentially would remove an edge, as I defined previously, from the network, and then computed the relative change in the structure function correlation. And then we could then define the contribution of each edge on the increase in that structure function correlation during seizures. So what we found initially, and this was actually done with data, older data, where we had used that grid electrocorticography approach. You can see this it looks different than the SEG pictures I've shown previously, but we showed that the edges that increased to that contributed to the increase in the structure function and coupling were largely short range edges, and similar. So this was actually really exciting work, because it was the first time anyone had attempted to connect these two modalities in patients. So we did, as I said before, share our code on GitHub, and I'm just going to share some the next steps of this project before wrapping up. So this is work that Andy Revel, who's a current MD PhD student in the lab, is working on as one of his many projects that he's doing. But he is using something borrowed from the social scientists called diffusion modeling, to try to model seizure spread and then correlate that with the observed real data spread, and see if we can predict surgical outcome and really see if there's kind of missing data points. So one of the main challenges of intracranial EEG, besides its invasiveness, is a sampling issue, in that we can't cover the entire brain with electrodes. So you're sampling, you have fairly sparse sampling in comparison to like a whole brain MRI, where you get sampling throughout the brain. So this is a seizure from our patient, and you can see we, in this case, tried to label the spread pattern. So that's going to be important in using it to validate the diffusion model. So the idea of the diffusion model is to try to predict spread patterns. So essentially, you can use you can model the spread from any node in the network, and then essentially we'll go on to try to compare it to the real spread. This is just a nice diagram showing that. If I can actually, let's see. Okay, there we go. So just in more kind of simple terms, you can see some examples. So if you seeded in the hippocampus up at top, you could then model how that would spread, versus if you sampled in the frontal lobe on region 2, you'd get a different model of spread. And then we can compare that to the actual observed spread from the real intracranial data. And so this is some work that Andy had been working on in the fall, where he was able to like simulate the seizure spread, as I showed before, and then basically was able to z-score the probable seizure onset zones. And this essentially is, I think, a really exciting approach, because it can give us insight into parts of the brain where we don't have electrodes placed. So what happened to our patient? He underwent a left hippocampal laser ablation, where just a laser is put in through a burr hole, a probe is put in through a burr hole, and that structure is lasered or burned. Unfortunately, his seizure returned after 1 year. And what was interesting from this initial work from Andy was that in his model, the left hippocampus was not the most probable seizure onset zone. And this is just a picture of the laser ablation. This is acutely right after the laser ablation, and then 6 months after, where you see that hippocampus is scarred down. Oh, sorry, I went too far. So I just wanted to kind of conclude just like final thoughts on this. I think interestingly, Andy's model predicted that a part of the brain that we did not sample from because of the thin temporal bone was the temporal pole was a possible site of the seizures. So, this patient has been doing a little bit better, but is continuing to have, he's definitely had substantial palliation of his seizures from the surgery, but has started having seizures again. And, one thing I think that we'll consider clinically, not based upon the preliminary research that I just went through, but whether or not to extend the amount of resection, which would then go towards a more standard left temporal lobectomy that might provide a better outcome. So that I think is about all I have time to go through. And I just wanted to list out my huge group of collaborators, but the group of students is growing and growing. I'm sure I'm missing some people on this slide. Danya has been a MindCORE student with us this summer, working with Andy and myself, and has done a really fantastic job. I think she'll highlight her work, which is looking at the difference between gray matter and white matter electrodes in intracranial EEG when she gives her research presentation, I think later this week. And then I've also fortunately had the privilege of working with Alex Silva, who was a MindCORE student last year. And he ended up, as Danya plans to stay in the lab for the year, taking course credit and an honors thesis. And Alex actually just started at UCSF in an MD PhD program. So really proud of the students that I've had the pleasure to work with through this program. And those are just the funding. And then a really beautiful, Andy is also a graphic art, a very talented artist. So he made this beautiful picture that fades away. So I'll open up for a few minutes of questions.
Thank you so much. That was fascinating. And I'm glad to hear that I actually hadn't heard that Alex had gone on to an MD PhD program, and I need that kind of information for a report to our funder. So thank you for that.
Excellent. Yeah, he got in everywhere. He had a 10 too, but decided he wanted a different experience. Maybe he'll come back one day, but he was very successful. So
good. That's always good to hear. I guess I'm a little bit curious. Let me just see. I want to just encourage anybody to post questions in the chat. And honestly, I often need help with questions because sometimes this work can be quite heady. And I didn't mean that as a pun. But I'm curious about how the shutdown actually affected your research and your clinical practice. It sounds like I know you have to go at 1 because you're seeing patients, and so what did that look like? Just out of pure curiosity.
You asked how COVID, is that what you said?
Yeah.
Yeah. It's been quite a ride. I think computational labs like ours, I think have done very well with COVID because we were really able to quickly adapt to online mentoring, and our data is all available remotely. So honestly, I think we've probably been more productive on the research side, although data acquisition was stopped for a few months. And we've since June, we've been acquiring data again. So I don't think it's actually substantially impacted the research side, which is great. Clinically, it's a whirlwind because there's different rules, just like there are out in the community almost every day for what's appropriate to be doing. But we did very rapidly switch to telemedicine, and then within the last month have been going back towards a goal of somewhere like 75% in person, but still doing some telemedicine. And our epilepsy monitoring unit, where we do these both scalp EEG and intracranial EEG evaluations, was closed completely for about 2.5 months because those are all elective admissions, but we reopened at the end of May.
That's good to hear. I'm sure it's a relief for people to get sort of back in the pipeline for finding some solution.
Yeah, honestly, I think that being at the hospital is very, very careful. There are really good safety precautions in place, and that it's probably lower risk to come in to the hospital than going to the supermarket.
That makes sense. We do have a question from somebody in the audience, from Dorian. Who says, starts with a compliment, great presentation of new methods, thank you. Is there any thought to use high power ultrasound, non-invasive lesions instead of laser or surgical lesions?
Yeah, so Dorian's referring to a technology that we actually do have at Penn over at Pennsylvania Hospital that's being used in Parkinson's disease. You can use this type of non-invasive ultrasound to either like stun tissue or actually irreversibly damaged tissue. And there's been some discussion about doing that in epilepsy, but I think there are some groups that are considering it. It's a difficult thing to start doing because essentially you'd need to, because of the safety concerns, first, just stun the tissue. I'm most interested in, like, if you could stun the tissue and do cognitive tests and whatnot to see if it's safe to resect that tissue, that would be really interesting, right? But you'd have to do that first in patients that you already plan to do a surgical intervention on that part of the brain. There hasn't been that much push towards that because laser has really come onto the scene in the last just few years, and we're still trying to develop bigger data sets to show us the cognitive difference, et cetera, cognitive outcome difference using that method. So it's complicated, but that's definitely something that I'm interested in, but we haven't pursued yet.
That'll be next. That'll be your next RO1.
Okay.
We have another question from Desmond Othis. Can your work inform improvements to neuropace by way of targeting, for example, or mainly about where to resect?
That's a good question. So what Desmond's referring to with neuropace, you have to actually decide where to put your electrodes. And right now you can only have 2 active electrodes with neuropace. So that is the defibrillator for the brain I mentioned at the beginning. So that's really limited sampling when you only have to pick. And unfortunately, for a lot of patients, to determine where to even put those electrodes, we have to do intracranial EEG. So if we had non-invasive imaging methods that tell you where to put those electrodes, it would be a huge improvement. And that's definitely something that our work, I think, could ultimately help with. But the reason why we don't resect in those patients is usually because it's not safe to do so, because it's from their dominant speech area or their dominant hand motor area, or they have multiple different areas of the brain that the seizures are coming from, like both hippocampi, which you can't, that's patient HM, which most of you are probably familiar with. That's not a good idea. So yeah, I think that's something that in the future it could be helpful with. But it's really, honestly, we're really still very much at the beginning of this type of quantitative network-based work in epilepsy.
I have a feeling you might be getting an email from Desmond because I think he does do work in this space.
Yeah, he does.
Okay. Well, I want to be conscious of your time because I know that you have patients to see at 1, and so we will let you go a little bit early so you have time to cross the street.
Great. Okay. Well, thanks for listening, and stay safe. Well, reach out to anyone's welcome to reach out to me on email if you're interested in discussing anything further.
And thank you always for mentoring our students. It's fascinating work, and we always have a ton of interest in it. And I truly appreciate that you spend the time to help them figure this out.
We've had some really fantastic students so far, so very rewarding.
Good. Great. Thanks again.
Okay, thanks. Take care, guys.
Goodbye, everyone. We'll stop the recording. Okay.